Well, while you're just sorting that out, I'd like everybody to give a warm welcome to the very lovely Dr. Siddharth Sethi. He is a gastroenterologist and hepatologist, and he has specific expertise in the shoving of cameras and things into people's orifices and having a good look at them from the inside and out. In particular, IBS, bowel cancer screening, gastrosphere and colonoscopies, capsule endoscopies. And if you have a look on Rate My Doctor and any of those other sites, you'll find that he is very, very well rated by his patients and well liked by those whom he serves. He's described as extremely knowledgeable by his colleagues, and we here at MAG find him terrific to deal with and one of our wonderful people that we have on board. I know that you will very much enjoy this presentation, which is on a very topical subject and very interesting to all. The doctor would like if you could reserve questions for after his presentation, please, but we will have time to take some Q&A at the end of it. So thank you very much. Go ahead, Doctor.
Thank you. Thanks for your introduction. Thanks for your kind introduction, Michelle. I'll just start. I'll just do the share. I'll just share the screen. Just let me. It said host disabled screen sharing. I might just let me share the screen. Thanks.
Sorry.
Can you allow me to share the screen? I can bring up my slides.
Yeah, sorry. That I thought I'd done that. It didn't do it. There we go.
Yep. Good. Thanks. Okay, so we'll get started now. Yep. But still showing as disabled.
Oh, okay. I don't know why that's not happening. Hang on a sec. All right, let me try again. Is that working?
Oh no, it still says disabled. It still says screen sharing disabled.
Right.
You know, it's easy if you bring it up. If you bring up the slides, and then I can.
Okay, let me just. I'm just trying to find the slides, to be honest with you, sir. Okay, hang on a moment. I'm just going to check with my tech guy. Give me 2 minutes. I'm so sorry.
Or I can email it to you right now if you like.
Yes, that could work.
I'll just send it to you right now. I'll just forward it to you right away. Oh, is it Michelle.Culane? How do you
Michelle.C.
Michelle.C at MAG?
Medicolegal assessments group.com.au.
I just sent it Michelle.C. I'll send it. You should get it now.
Okay.
Has it come through to you, or?
I'm just waiting. Just communicating to my tech guy. I do not know why this is not allowing screen share. Okay, our tech guy is saying, can you log out and then log back in again?
Okay, so
I'm so sorry.
I'll leave the screen, guys.
Okay. Okay, sorry about this, everybody. The last one I hosted went seamlessly.
Oh.
Okay, we've got the doctor logging back in again.
Dr. Sethi, I believe you're on mute. Hi, Michelle.
Medical legal assessments group.
So, Dr. Sethi, you're unable to share your slides, is that correct?
That's correct. It's not letting, whenever I click share screen, it says host disabled participant screen sharing.
Okay, Michelle, would you be able to make me the host very briefly and I can just have a look?
Yep. Now,
so if you click on my user, if you click on more next to my name, there should be a make host button.
Got it.
Okay, Dr. Sethi, what I'm going to do, I'm actually going to, let me just check. If I click share screen. Okay, so Dr. Sethi, what I'm going to do, I'm going to make you the host of the meeting, and then we'll see if that works in enabling screen sharing. So, okay. Dr. Sethi, you're now the host. Would you mind trying to share your screen now?
So I'll try it now. Yep, I'll just open the slides first. Yes, now it's working. Good. That's good.
Okay, all good.
Good.
Thanks, Ogden.
No worries. I'll just stay in until it's all going ahead.
Okay, we're ready to go now. Okay.
Yep. Okay. Thanks, Dr. Sethi.
Good. So I'd like to thank everyone for joining me, for taking time out of their schedules to join me today. I'd like to thank Mag and especially Michelle for organising and Sophie for organising the meeting for today. So today I'm discussing gastroesophageal reflux disease as well as irritable bowel syndrome in a medical legal setting. So these are both very common conditions and they often come up in medical legal assessments. I'd say they account for the overwhelming majority of most gastroenterology IMEs or work cover or assessments. We see them very, very commonly, and there's a number of issues that come up which I'll be going through today. So my background is I'm a gastroenterologist, hepatologist. I commonly see GORD and IBS in a medical legal setting. I'll start with GORD or gastroesophageal reflux. It's often known as just reflux for short. It's a fairly common condition. It affects about 15 to 20% of the population. It can occur pretty much at any age. It can occur in young people as well as older people. It doesn't very commonly occur in young children, it only occurs in adulthood, but it doesn't seem to get particularly common with increasing age. So if it does get more common with age, it's more due to weight gain. So essentially, in essence, it's a chronic condition where stomach contents originate in the esophagus and then rise up from the stomach and rise up into the esophagus. Now, the symptoms are variable. They can be different for different patients. The most common reflux symptom is a retrosternal burning sensation, which starts in the epigastrium and comes up into the chest. It can go into the mouth. It can cause a variety of symptoms in terms of burning, bad breath. It can present as chest pain. So typically people have either retrosternal or stomach pain. It doesn't usually radiate to the back, and it can occur pretty much any time of the day. It's typically often worse at night after having a big meal. So a scenario would be someone would have would skip lunch, skip breakfast, skip lunch, have a big dinner, and then have a big meal, and then lie down and sleep shortly afterwards. Classically, they would often get bad reflux subsequently. So reflux can also present in different ways as well. It's known to cause dental erosions or breakdown of dental enamel. It's commonly, so not uncommonly, gastroenterologists are referred patients by dentists saying they have dental erosions for which they can't find any other cause. It can also lead to respiratory issues. So it was discovered some years ago that patients can often present, patients with GORD can often present with asthma or pneumonia as a result of aspiration of acid content into the lungs. So nausea is typically seen in patients who have severe reflux. It's not normally seen in mild to moderate reflux. It can also present as a cough that's thought to be from laryngeal irritation. So the acid comes up and irritates the larynx. One of the more dangerous complications of chronic long-term reflux is a condition called Barrett's esophagus. So that's where patients suffer acid reflux over a number of years. It leads to changes in the lower esophagus that can eventually progress on to causing esophageal cancer. That's present in about 1% of the population. In terms of the causes, now this has been extensively researched and studied. It's most commonly caused by laxity of the gastroesophageal sphincter valve. So typically it's not a anatomical sphincter, it's more of a physiological mechanism. So the idea behind it is that in non-medical terms is that acid is meant to remain predominantly in the stomach. It's meant to help break down food. It's not meant to be in the esophagus at all, but what can happen is if the valve becomes lax, acid goes upwards into the esophagus, it causes burning, irritation, and that's usually been caused by laxity of the sphincter. So in terms of the physiological mechanism, typically the sphincter valve is meant to be tight. What can happen is in GORD it becomes lax and weak, it allows reflux to occur. So there's several conditions that are known to worsen reflux. A common one is hiatus hernia. So that's where the muscle lining under the diaphragm becomes lax and weak. It moves upwards, and what that does, that disrupts the sphincter mechanism. Another condition that makes reflux worse is obesity. So the mechanism behind that is particularly patients who have excess weight around the waist. What that does is the extra body weight tends to push acid upwards. So that's typically seen with abdominal obesity. Smoking is also well described in the medical and scientific literature to worsen reflux. It also works by weakening the sphincter valve. This is an anatomical mechanism of how reflux operates. So if you imagine this as being the stomach, and that's a gastroesophageal sphincter valve. In slide A, we have a very tight valve that allows acid, that makes sure acid remains in the stomach. In slide B, the valve has gotten lax and weak, acid is going upwards, it's reaching into the esophagus. In terms of the diagnosis, it's typically diagnosed clinically. Anyone with a suggestive history, one can very reasonably make the diagnosis for this condition. But the patients can often also undergo gastroscopy. Now, the purpose of gastroscopy is for a number of things, a number of purposes. It's mainly to check to see if there's been it's to confirm the diagnosis of reflux. So it's to check for any, to make sure any damage has occurred. It's also made to rule out any concurrent conditions, so to make sure they don't have another condition that might be masquerading as reflux, like a peptic ulcer. So peptic ulcer can often masquerade as reflux. The key difference is patients with ulcers tend to have more severe symptoms. They tend to have nausea, vomiting, bleeding, which should normally occur in mild to moderate GORD. And typically their pain usually doesn't radiate upwards. It's usually confined to the stomach in most instances. And also ulcer pain classically, as reported in textbooks, radiates to the back. Reflux pain usually shouldn't do that. So gastroscopy can be performed for diagnosis as well as to rule out other conditions. But patients don't always have to have gastroscopy. The general thinking is that anyone having mild to moderate reflux without any alarm symptoms such as difficulty swallowing or dysphagia, nausea, vomiting, non-response to treatment or severe symptoms normally don't need to have gastroscopy. Anyone who has a symptom should ideally do it. It's also often done for anyone above the age of 40 or 45. Reason being is to make sure they don't have gastric cancer. So gastroscopies are relatively easily done tests and quite readily available. The other option is to perform what's called esophageal pH monitoring. Now, the reason behind that is gastroscopy can be somewhat insensitive for reflux, and the patients can often have very severe reflux but have very little to find on endoscopy. This is a well-described phenomenon. So up to 50, so GORD is one of those conditions where the findings on gastroscopy don't always correlate with what you find endoscopically. So patients could have very severe reflux symptoms and very little to find on gastroscopy, or alternatively may have very severe reflux damage and relatively very little symptoms. This is where esophageal pH monitoring comes in. The role of this test is to objectively check for the presence of reflux, and then this allows monitoring in response to treatment. So the idea behind it is that it's a relatively unique and niche test. It's not commonly done. I might only send people for this maybe once or twice a year, not more often than that. It's used for patients who don't respond to treatment, and it's an objective test to see if there is actually reflux occurring. And it can also be used for monitoring purposes as well. This is a slide showing a typical patient with acid reflux. So that's looking down, top down from the esophagus into the stomach, and you can see here the irregular jagged outline. That's all, this red area is all where acid has come up and eroded into the esophagus. So reflux is graded into different degrees of severity. There's LA grade A, B, C, and D. A and B are relatively mild. You can see there's relatively mild changes. When you get onto grade C, it becomes more severe. By grade D, it's very severe. This patient has erosive ulcerative esophagitis. This patient has very severe symptoms. So patients with grade C and D, you'd expect to have symptoms like difficulty swallowing, bleeding, and weight loss. You would not expect those symptoms in grade A and B. So most patients fall into the milder categories. The majority of patients don't have severe disease. If they do, they typically would have underlying factors. Not often, but not always, they'd be obese or smokers. But then again, you often have slim non-smokers with very severe reflux. I should mention at this point, reflux does not have a hereditary component. It's one of those conditions which is very common, so it's hard to argue a genetic component. In terms of the differential diagnosis, we should, the other condition to make sure they don't have, in addition to peptic ulcers, is also heart disease, particularly for elderly patients, such as elderly males. So it's not unreasonable to order an ECG, electrocardiograph, or a chest X-ray to make sure there's not another condition which is masquerading causing the chest pain. In terms of the treatment, it's commonly used with, commonly we'd use proton pump inhibitors, such as Somac, Zoloton, or Nexium. So I should give some historical perspective. These have been around for about 20 years. Prior to that, patients were taking antacids such as Gaviscon and Mylanta. They're still used, but not as commonly. They don't work anywhere near as well. So the Mylanta, Gaviscon, ranitidine, Renes, they simply work by buffering stomach acidity. The medications like Zantac, ranitidine, they work by reducing stomach acid production by about 70%, 80%. The proton pump inhibitors do so by almost 100%. So they're very, very effective treatment. They're very safe to take long term. There was some suggestion some years that PPI therapy might lead to cancers. That's not been proven. That they're thought to be fairly safe. In most instances, they can be taken once a day. They can be taken in severe cases where they're not responding. You could go up to twice a day if required, but that's usually not needed for most patients. Once a day is usually enough. And they don't need treatment every day. It's very reasonable. This has been confirmed in scientific studies. They can be taken on an ad hoc or as needed basis. So what I recommend to patients is if the days they feel the reflux is playing up, they can take it then. The days it's mild or moderate, they can give it a miss. I'm very happy for patients to do that, and most gastroenterologists are as well. Other changes are lifestyle changes, which I mentioned earlier, like not lying flat after meals. So the advice being to leave at least 2 hours between eating and sleeping. So ideally being if you have a big meal at night, wait at least 2 hours before going to bed, or if need be, you can prop yourself up on a pillow. I should mention that PPI therapies are very effective. Once people on PPI therapy, they don't usually really need to follow the lifestyle measures so much. They're often very effective. Certain foods such as coffee, alcohol, chocolate, fatty or acidic foods, they're also known to worsen reflux. They also fall to they mediate this by relaxing or weakening up the valve. Weight loss can help in patients who are overweight. So what can happen is reflux can either disappear or substantially improve. They often need less treatment subsequently. Avoiding alcohol and smoking is often a big help as well. So not so much mild to moderate alcohol consumption, but binge drinking should ideally be avoided. In rare instances, patients do end up needing surgery for GORD. Patients don't always respond to treatment. A proportion of patients don't work. So often I try using double dose PPI therapy or a different agent. But in some cases, patients do need to be referred for surgical therapy. The main operation for this is what's called a Nissen's fundoplication. I won't go into too much detail about it, but mainly they rewrap the upper part of the stomach around the lower esophageal sphincter valve. That strengthens the sphincter and prevents reflux from occurring. This is not a commonly done operation. To give you some perspective, I probably only send 1 or 2 people a year for this surgery, so really very rarely done. It's really a last resort. It's not meant to be used first line. Reason being is it's a fairly major operation. It requires usually it would require a few days hospitalization afterwards as well. The other problem with this operation is it's not a permanent cure. Unfortunately, it lasts around 15 years on average, which is problematic because they need to be redone. So if you had someone who was, say, in the early 40s, they could have the surgery, but then the problem being that they might need it redone by the time they're 60, and that's really not ideal. I should mention nowadays a lot of patients are having bariatric surgery in terms of gastric sleeve or gastric bypass. They are at very high risk of getting GORD because their gastric anatomy has permanently changed. So what's happened in such patients is an unintended byproduct of weight loss surgery. Because the stomach is much smaller, the normal anti-reflux mechanisms don't work as well. So they're at very high risk of getting gastroesophageal reflux. Such patients tend not to respond very well to medical therapy. They often need further surgery and or high-dose medication. And this is an unfortunate, under-recognized complication of weight loss surgery. So it's not something that's probably well known to the general public that well. Coming on to GORD in a medical legal setting, so patients who take medications such as endone, Panadol, codeine, non-steroidals, they often are prescribed this for alleged or actual work injuries. They may have done heavy lifting at work and then claim to have had a bad back or bad shoulder afterwards. They commonly claim that they've taken such medications that subsequently develop GORD. So this is incorrect and is not accurate. It is not supported by the medical and scientific literature. So such medications usually do not cause reflux. They don't have a significant effect on reflux at all. So the main cause for GORD is by far and away sphincter laxity. And these medications usually don't have much effect on them at all. So I should mention non-steroidals like Nurofen, Voltaren, Mobic, and Indocet can cause gastric or duodenal ulcers. They do not cause reflux. And often patients claiming to have developed reflux after alleged work injuries are often obese and smokers. That's commonly a contributing factor to them getting reflux as well. So coming on to my case history, I'm giving a case history of a patient by the name of Mrs. Smith. She's a 35-year-old lady who works as a computer analyst. She presented to me for an independent medical examination. Her past history is 3 years ago. She was involved in a motor vehicle accident, which from the accounts from her accountant as well as the written report it was a fairly minor impact. There was a low intensity impact at a roundabout. The airbags never deployed. She wasn't taken to she was able to get out of the car and leave the scene by herself. The car only had some minor scrapings. It wasn't written off or anything. She wasn't taken to hospital. She didn't even need to see a doctor straight away for some time. So just from that account, it was a fairly trivial accident. She presented to her GP around a year later claiming she had severe reflux symptoms. She claimed that trauma related to the accident had caused it. She felt that she developed or sustained significant damage to the gastrointestinal tract as a result of her accident. Notably, the accident happened in May. Her symptoms started 7 months after, in December of that year. So there's quite a long gap in between where she had no symptoms at all. Her description was the classical gastroesophageal reflux, retrosternal burning sensation, radiating upwards, it was felt frequently, all day, every day. There was virtually no days where she didn't have it. It often kept her up at night. She was commenced on PPI therapy with Somac. She didn't have much of a response to this agent. The medication was increased to twice a day. That didn't really make a difference. She even attempted to lie flat after meals. That didn't make much of a difference either. She also claimed to have a sore shoulder, which occurred as a result, what she claims as a result of the accident. She was prescribed Voltaren as well. So she made a CTB claim, was referred to see me. Prior to seeing me, she'd gone to see another gastroenterologist who did an independent medical examination on her. He argued that the accident along with Voltaren had caused her to develop GORD. So his reasoning was that the accident had caused nerve damage to the intestine, which had led to her developing reflux. And he also claimed that the Voltaren had caused valve laxity and led to having reflux. So when I saw this patient, I noted she was obese. Her body mass index was 35. The normal range is up to 25. That classifies it as moderately severe obesity. She smoked 20 cigarettes a day, had been doing so for many years. So although the patient did not volunteer this, after reading her medical records, I found she'd had endoscopies on 2 separate occasions in the past, in 2001 as well as 2010. So admittedly, these were several years ago, but that still occurred, and it still had occurred. Importantly, the patient, when directly asked as to why these procedures were performed, was rather vague and non-committal. She claimed they were done as a routine check and not to investigate any particular symptoms. So I should mention here at this point is that patients who have signed up to the National Medical Record e-records, often information will come out of there that patients don't always volunteer themselves, whether they forget to mention or deliberately omit to mention. Often a lot of information will come up from past medical records. So it's probably worth requesting that. Often you'll be surprised as to what you could find. You'll be surprised, the patient will be surprised as well. I concluded that this patient's accident was not responsible for her symptoms. My reasoning was as follows. The original accident was a fairly low intensity impact. There was essentially very little injury here at all. She walked away from the scene, didn't require any medical attention. I felt that my colleague gastroenterologist claimed that she developed significant injuries, nerve damage was incorrect. I felt it was highly improbable and highly unlikely. My rationale was that if she'd suffered severe injuries enough to cause her to have reflux and nerve damage, she should have had at least, one would reasonably expect abdominal pain at the time. She didn't complain about it at all. She'd had scans done later, which didn't show anything. So I felt that there was no proof to that at all. I pointed out the long period of time, 7 months between her accident and the symptoms occurring. So had the accident been responsible, one should have reasonably expected them started within a few days or the most weeks. The 7-month duration essentially ruled out any causative role for the accident. I felt the pre-existing smoking and obesity had played a strong contributory role. The fact that she had endoscopies twice in the past showed that the condition was clearly pre-existing. Notably, this patient did not reveal her previous gastroscopy, so gastroscopies usually are not done as a routine screen. That's not correct. They're usually done for symptoms. The fact that she didn't disclose these gastroscopies raised doubts about her veracity. I felt there was no reasonable anatomical or physiological mechanism whereby her accident could have caused her to develop GORD. She'd had a gastroscopy performed a couple of months before I saw her, which did not show any peptic ulceration or anything else. From that, I concluded the Voltaren did not lead to any gastrointestinal damage. So I'll now discuss irritable bowel syndrome, or IBS. So IBS is a very, very common condition. It affects 15 to 20% of the population. It accounts for, I would say, 20% of most gastroenterologists' workload, if not even more. So if any given day, the majority of patients one would see in clinical practice would be experiencing IBS. There's different patterns of IBS. It can be diarrhea predominant, where they go to the toilet several times a day. Motions are loose, runny, and watery. They can have constipation predominantly, they have more constipation, or often people can go back and forth, have alternating constipation or diarrhea. I should mention women tend to have more constipation, men tend to have more diarrhea. That's due to hormonal factors. Now, in the vast majority of instances, IBS comes on chronically. So usually it's hard to date the symptom onset. When patients are specifically questioned, they can vaguely date as to when symptoms occur, but they usually can't narrow down a precise date. It's unlike a heart attack or a stroke where you can nail down the date and time you had it. It can't usually be done with IBS. There is one exception to this. There's a condition known as post-infectious IBS, where patients get IBS after having a gastrointestinal infection. Such patients typically develop IBS shortly afterwards, but I won't get into that in too much detail. But in those cases, it's relatively acute in onset. So IBS is typically recurrent and chronic, but can be acute. The typical symptoms are abdominal pain, discomfort, bloating, excess gas, and distension. Typically, patients have irregular bowel habits, as I mentioned, diarrhea, constipation. They commonly have urgency. They have to rush to the toilet to pass stools. They often will have a condition known as tenesmus, where they don't feel that they fully empty their bowels. Symptoms are sometimes relieved by going to the toilet. Patients with IBS are often more likely to have GORD, they can have chronic fatigue, they can have fibromyalgia, headaches, depression, anxiety. So it often correlates with the number of, often patients who have IBS have concurrent other conditions as well. But I should mention those conditions are associations, they're not cause and effects. So having chronic fatigue, fibromyalgia, headache don't cause you to develop IBS. No one knows the exact cause of IBS. It's thought to be related to the gut-brain axis. It's so the most plausible theory people come up with is what's called visceral hypersensitivity. So the nerve lining of the intestine becomes exquisitely sensitive to the brain. The conditions that make it more common are gastrointestinal infections, as mentioned. They have acute diarrheal illness. It's more common in young people. It's often, so the peak incidence, age of incidence is 15 to 35. It's also more common in women than men. There's, I think, 2-to-1 female predominance. It does overlap with fibromyalgia in terms of and chronic fatigues, but I should mention IBS doesn't normally cause chronic fatigue in most settings. It usually doesn't make you sleepy or tired. I should mention here that the depression, anxiety, panic attacks do not cause or influence the onset of IBS. So stress has commonly been postulated as a cause, but it's never been proven or established in any clinical trial. Stress, I should mention, is a very subjective quantity to measure. Hence, for that reason, it's very hard to prove a causative link. There's never really been a scientific trial or study that's shown it. And in fact, because it's so subjective, it'd really be very hard to measure. I should also mention here that stress has been linked to multiple other conditions besides IBS, such as heart disease, cancer, autoimmune conditions, but this remains purely speculative. It's purely a hypothesis, never been proven or established. So I think quite confidently state that the majority or overwhelming consensus of medical and scientific opinion is that stress does not cause IBS. Any linkage or suspected linkage is tenuous and highly speculative. I should mention that here that patients in making medical legal complaints often claim that the stress of their workplace condition caused them to develop IBS. That's not correct. There is no specific diagnostic test for IBS. There's not really any one test. Typically, but in routine practice, if someone has the typical symptoms along with a normal gastroscopy, colonoscopy, you can be fairly sure that you have IBS. And then in that setting, it's unlikely to be anything else. So the diagnosis is mainly based on symptoms, as with other conditions in medicine. The conditions or the symptoms that would make you suspect something else would be onset after the age of 40, weight loss, severe pain, nocturnal diarrhea or getting up at night to pass stools, anemia, rectal bleeding, family history of bowel cancer, inflammatory bowel disease or celiac disease. Those conditions should make you suspect something else. there's what's called a Rome-4 criteria for diagnosing IBS. So patients who have typically recurrent pain at least 1 day a week in the last 3 months, associated with at least 2 of the following. So related to defecation or change in either the frequency or the appearance of stools. But one should be sure that a patient does have IBS, not anything else, because it is a functional condition, not an organic condition. So one should make sure there's no colon cancer or polyps or inflammatory bowel disease, thyroid disorders, celiac disease, or infections. Less common causes are carcinoid syndrome or microscopic colitis. Investigations typically involve stool microscopy and culture, blood tests, including full blood count, liver function, and celiac serology. Patients might have abdominal ultrasound, but typically gastroscopy, colonoscopy, and as mentioned earlier, a normal gastroscopy essentially confirms the condition beyond any doubt. So, in terms of dietary treatment, the most common treatment nowadays is what's called a low Fodmaps diet. So Fodmaps this was interestingly discovered locally here in Monash University in Melbourne, so it's a local invention. They're essentially, Fodmaps are short chain carbohydrates that are not well absorbed in the small intestine. They're subsequently fermented by bacteria in the distal, small, and proximal large intestine. So the resultant production of gas leads to bloating and flatulence. So Fodmaps don't cause IBS, but rather when a patient develops symptoms when the condition, so what happens is patients develop symptoms when the bowel response is exaggerated or abnormal. Low Fodmaps diet involves usually restricting or avoiding them from the diet. So low Fodmaps should only be recommended for confirmed IBS patients. It's not recommended for children. It's problematic to follow in that it can be hard to follow. It's quite restrictive. It avoids a number of food groups such as basically food groups such as bread, wheat, dairy products, stone fruits. It's really quite hard to follow in most cultures. Most cultures eat bread very routinely. Other problems, you have to avoid garlic as well, which is becomes quite restrictive as well. In terms of medications for IBS, the medications for this are usually fairly unsatisfactory. They usually only work in 25 to 30% of patients. In patients who are constipated, you can try soluble fiber supplementation. The idea is to act as a bulking agent. You can use antispasmodics like buscopan and Colofac to relieve cramps and diarrhea. Antidepressants can also be used as well. So for these, for antidepressants, one normally uses a tricyclic antidepressants. The sort of the modern antidepressants like the SSRI, like meclobamide or fluoxetine or Prozac, don't tend to work as well. There's some evidence for psychological therapies like hypnosis, meditation. I usually don't recommend them. Probiotics and herbal remedies are often tried by patients. Doctors don't usually recommend them very often. The efficacy of these agents is very low to unproven. They're really not effective at all. And the other problem with these agents is they're not especially cheap. They're not covered by Medicare, so they're not really. It's not really feasible to take them long term. So coming on to IBS in a medical legal setting, patients commonly claim to develop IBS after work accidents. So there's a colleague of mine who I won't name him, but he commonly does IMEs for plaintiffs. What he claims is that patients who have IBS have developed a so-called stress and anxiety response, and that response continues to drive them to develop IBS. But that is unproven and not supported by the literature. So typically the stress of the accident, analgesia that they got after is usually cited as a causative factor. I should mention that analgesic medications can often cause constipation. They usually do not cause diarrhea. So any patient having constipation, diarrhea, or both, usually should not have reasonably risen from analgesic agents. So patients with IBS often have other symptoms like bloating, gas, wind, reaction to certain foods. Those are not caused by medication. The only IBS symptom that you could say analgesics do cause is constipation. So the timing of onset of the symptoms is critical. Patients will typically have a past history of the condition if it's pre-existing, which means that it wasn't from the accident. If the condition has arisen several months after starting medication, I think one can reasonably say that that wasn't the causative factor. not quite commonly, patients have stopped the offending alleged medication, but yet if the symptoms persist afterwards, from that you can conclude that the medication also wasn't responsible. So because usually if a medication was responsible, it should reasonably start within a few days or weeks. So really, if they have diarrhea, you can conclusively rule out any causative role for analgesics. Often, if they've had a previous endoscopy or taken PPI therapy, antispasmodics in the past, it's a common clue that it's a pre-existing condition which they're perhaps not being entirely forthcoming about. So, to finish up with, I'll run through an IBS case history. As a 48-year-old gentleman who previously worked in a warehouse, 5 years ago, he allegedly sustained a back injury performing heavy lifting and ceased work afterwards. He soon after had an MRI of his back showing disc prolapse and developed chronic back pain. He was commenced on a number of analgesic medications like Endone, Target, and Lyrica. 2 years later, he began developing abdominal pain and irregular bowel habits. He had typical IBS symptoms where he had tight pressure, he felt bloated, gas and full, his stomach felt windy and looked distended. His bowel habits were mainly constipated, but he had occasional diarrhea. He was finding that certain foods like garlic and bread would upset his stomach. He had an endoscopic colonoscopy in 2018 that was reported as normal. He was later started on laxatives as well as a low Fodmaps diet that was partially effective. So he lodged a work cover case and saw independent expert. The expert report claimed he had a medication-induced, so the diagnosis given to him was a so-called medication-induced gastrointestinal motility disorder and stress-induced IBS. He was rated as having 5% whole person impairment for the gastrointestinal tract. I think it was 3 for the top, 2 for the bottom. The expert claimed that the analgesic medications he was prescribed were responsible for his symptoms. He also claimed that stress from the accident, the subsequent claim, and loss of income were also responsible for him developing IBS. So he came along to see me. I concluded that the claimant's employment, accident, and analgesic medication did not play any role at all. I felt that the condition developed regardless. So the factors I summarized in my report were the long period of time, the 2-year gap between him starting analgesia and having symptoms. I felt that went very strongly against any causative role. I felt if the medications had been responsible, they should have started soon afterwards. I felt that the symptoms he was describing were not reasonably accounted for by the medications. He had diarrhea, he had bloating and excess distension, which I didn't think were commonly caused by medications. I felt they were more in keeping with IBS and from medications. I pointed out that his original back injury did not directly involve the gastrointestinal tract. I commented that analgesics should not normally cause diarrhea. The fact that he had alternating diarrhea, constipation pointed against medications. I said that stress was too subjective to link to IBS. I added links to journal articles concluding that stress should not reasonably be linked to IBS. I also disagreed with the independent experts' calculation of 5% WPI. I felt the correct figure was 0. I commented that the expert that the claimant had used had not correctly followed SERA or work cover guidelines. Patients with no signs and only symptoms should be correctly rated as 0% WPI. So in summary, GORD and IBS are both very common conditions in the general population. They're caused by laxity of the gastroesophageal sphincter valve as well as by visceral hypersensitivity. Analgesics don't usually cause either GORD or IBS. They can occasionally cause constipation. They don't normally cause reflux, bloating, gas, reaction to foods, or diarrhea. And this is commonly claimed following workers' compensation claims. That's all. Any questions anyone would like to ask me?
Can I make a few observations? First of all, it was a very full, description, and I would agree with both your assessments of the two patients. With regard to GORD, first of all, it's quite common in women, pregnant women, particularly in the last trimester. I think something like a third of the women will have it. Next thing is that even if you cannot see any significant changes in the lower esophagus in GORD patients, taking biopsies will sometimes show you evidence of reflux. And also, if patients are on certain drugs, particularly with atropine-like action, for example, the tricyclics, this can cause or make worse any GORD. With regard to the irritable bowel syndrome, often the patients will, particularly women and in diarrhea patients, they'll get their symptoms in their late teens or early 20s. And they sometimes have passage of mucus, often colorless or white, as part of the symptoms of the irritable bowel syndrome, and can help you make the diagnosis. And I certainly agree with you that the irritable bowel syndrome is not caused by stress, but quite a lot of patients will tell you that they have worse symptoms when they're under stress.
Sounds fair.
That's true, but there's not a, I agree with that, Dom, there's not, it's not, that's an association, it's not a cause and effect though.
Agreed.
Mm.
Can I ask a couple of questions? Sorry.
No.
Is everyone able to hear me? I've had terrible computer trouble.
Yeah, I can hear you. I can hear you.
Okay, Siddarth, hi, it's Dr. Simone Ryan. I'm an occupational physician with generalist background. Thank you. I found that really helpful. I don't get to attend many of these, as Wednesday's my big MAG day. To Don's point, I wondered, I see a lot of people in long tail claims for insurance companies and return servicemen and women. So I have a couple of questions, and forgive me for taking some of your time, but with respect to polypharmacy, I mean, I understand the cause and effect. If there's a Voltaren and it sort of, you stop it and it doesn't change things, that it's probably not causative. But is there a point at which multiple polypharmacy can even exacerbate some of these underlying conditions? Exacerbation, of course, being then compensable related to the injury if those medications were used for that injury. So I have a professional interest in pain, and one would argue that sometimes polypharmacy in the pain scenario does exacerbate some of these underlying conditions. Is that a thing?
No, I would respectfully disagree. I don't think polypharmacy specifically causes GORD or IBS. No, it does not. That's not been shown or proven, no.
And what about increasing, I don't know, that's why I'm asking you, it's not my opinion. What about increasing experience of symptomatology of an underlying condition, like worsening it?
Usually doesn't do that either, no. I think it's at best a weak association. It's never been shown to be a cause and effect. And if you look at the pathophysiology of the diseases, that there shouldn't be either. They shouldn't have a cause and effect.
Thank you. And my second question is around returned servicemen and women. I understand from your presentation that psychological conditions such as PTSD probably aren't associated with gastrointestinal upset, although by the time they come to see me, there's already a whole range of accepted claims that need to be reviewed. My question really then is around returned servicemen and women and the type of food that they have been afforded for lengthy periods of time, particularly in long and active deployments where the food is highly processed and some people may have these underlying conditions. Could it be that they develop whether an exacerbation or a worsening of their experience related to food?
No, I would disagree. The only thing I can think of would be if they were to gain weight as a result of eating perhaps too much processed food. That might technically exacerbate both reflux as well as IBS. That's never been the subject of a claim, and one could also argue that the weight gain is more from excess calorie intake rather than just eating processed foods. That they may have chosen to eat too much of the processed foods may have been the cause and not exercised enough.
Thank you.
With regard to food, if the person is eating a lot of fat, for example, this may have a tendency to increase gastroesophageal reflux.
Yes.
Thank you.
That's correct. I agree. Fatty food, excess intake of fatty foods could potentially worsen gastroesophageal reflux, but then that's more of a lifestyle choice. It's hard to pin that down. You shouldn't be blaming the person's appointment for that. It was a choice, the lifestyle choice they made.
Oh, I don't agree with that. In long active deployments offshore, I don't agree that they have a choice of what they get to eat in many of those occasions for very long periods of time. It's often high calorie, high fat because it's very small rations, compact, high calorie, low nutrient, but high energy because it may be days before they get their next set of rations.
Any other questions, people? I'd like to just take this quick opportunity to thank Dr. Sethi for what was a very thorough and very interesting discussion. I found those 2 case studies very interesting myself. This is being recorded, so you will all have access to have a look at this again on our platform. Any other questions people would like to raise? No?
Can I just mention one thing? If patients are on NSAIDs chronically and they have abdominal pain, the possibility obviously exists that they could be having pain from a peptic ulcer, gastric or duodenal ulcer, and therefore their symptoms may be related to, let us say, injury for which they're taking the NSAIDs.
That is correct, but then such patients had often had a gastroscopy. If nothing was found in terms of ulceration gastroscopy, you could pretty much disprove that, then yes.
Sure.
Wonderful. Thank you so very much, Dr. Sethi. It was really terrific to have you. Very, very grateful.
Thanks for inviting me.
Bye-bye.
Thanks, bye. See you.
And thank you for helping us all actually see the slides.
Please. Okay, thanks everyone. Thanks, Michelle.
No worries. Thanks a lot. See you next time.
See you soon.